Hello, everyone. Thank you so much for joining me in this post-EHA, post-ASCO summer MPN updates. I'm really proud and honored to have been asked by Professor Mohammed Modi and the IACH team in order to do this, which has continued to be a fantastic educational platform. I'm Naveen Pemmaraju, Professor of Leukemia at MD Anderson Cancer Center in Houston, Texas. And so to begin our MPN updates, I think it's important to take a look back in the past, not so distant past, only 10 to 15 years. And in the myelofibrosis field, which I will be focusing the majority of my comments on here, the field is entering into a new golden era of therapeutic approaches and new research developments. Let's make sure we understand the fundamental basis of myelofibrosis JAK inhibitor therapy so we can understand all the results I'm going to show you and why they're exciting. So the COMFORT studies 1 and 2, led by Professors Verstovsek and Professor Harrison, really set the baseline fundamental goals of our field, which is spleen and symptom improvement. The ruxolitinib as single agent, first-in-class JAK1, JAK2 inhibitor, showed approximately 42% SVR 35, the spleen volume reduction at 35 weeks versus just less than 1% in placebo, and then symptom burden of 46% in the ruxo arm versus only 5% in the placebo arm. So let's remember those general numbers for intermediate high-risk myelofibrosis treated with a JAK inhibitor monotherapy. Now, before I show you some of the exciting results and combination data, the sobering part of this is that the majority of our patients, the vast majority treated with these single-agent approaches, are not cured. They're never cured. And in fact, as our colleague, Professor Palandri, showed, that life after JAK inhibitor is not always as long as we expect or as good. With at 3 years, approximately 41% of patients have stopped taking their ruxolitinib. Baseline predictors for this include what you would expect: higher disease burden, lower blood counts at baseline. Most of these reasons are for not good reasons, so lack of response, loss of spleen, AEs, progression of blast phase, etc. A few of these patients were for a good reason to go to allogeneic stem cell transplant. The supposition is that after ruxolitinib has not worked for our patients, you take a more chronic disease and it now turns into a more acute disease with overall survival median, unfortunately, less than 2 years in many of our patients. The use of investigational agents in this retrospective Italian database outcomes was associated with improved outcomes versus conventional agents alone. And so that brings us to the modern era of what we call the disease modification era, which is, can we design either single agent therapies, whether they're JAK inhibitors or beyond, or combination therapies, JAK inhibitor plus something else, either at the time of suboptimal response or frontline combination, to sort of attack the overt, primarily myelofibrosis early and try to aim for deeper, better, more durable remissions, move beyond spleen and symptoms, and perhaps even show markers of biological, molecular, and biochemical disease modification. And can we tie that into progression-free survival, EFS, OS, et cetera? And so with that, a number of different agents are being developed in the MPN field. Just for a broad overview, Pvera has had a few nice developments, including clinical trials and approvals of the ROPEG interferon in 2021, with the rusfertide in late-stage clinical trials. ET has had some developments. Systemic mastocytosis has had several approved agents and clinical trials, mainly focusing in the KIT inhibitor space, now moving beyond KIT. Rare diseases such as the 8p11 syndrome, FGFR, have an approval now, pemigatinib. And then, of course, in myelofibrosis, which is what we'll be focusing from here, in addition to the JAK inhibitors of ruxolitinib and fedratinib, those were the first two approved. We now have pacritinib, which was approved in 2022, platelets less than 50 frontline and relapsed MF, and then momelotinib, which is approved for MF with anemia. So 4 approved JAK inhibitors in the US. For the novel approaches, we'll mainly focus our updates on the combinations, which will be BCL-XL plus ruxo, navitoclax plus ruxolitinib, BET inhibitor, pelabresib plus ruxolitinib, and then the emerging program of XPO1 inhibitor, Selinexor plus ruxolitinib. Of course, there's a whole field of novel agents that are beyond the JAK inhibitor pathway, can be given as single agent. And then, of course, anemia and myelofibrosis is getting a lot of great attention with agents, both JAK inhibitors and beyond, that can either improve anemia or the second agent helping the anemia. All right, so with all these novel agents, how does one keep track? It's actually becoming very difficult in a good way. I would say I'm having to update this graph and table and figure essentially once a week as new trials are coming out all over the world. And that's a good thing for our patients and our research field. As you let your eyes scan this, I think one of the most exciting developments now is the so-called mutant-specific or mutant-selective approach, either targeting CALR extracellularly or JAK inhibitors intracellularly directly. And I think these clinical trials are now hitting phase 1 into the clinic. And then, of course, you have a whole host of novel agents well beyond the JAK and CALR pathways, hoping to either help or add to myelofibrosis patient outcomes. So let's review. I've selected 4 particular abstracts, talks to focus on, both from ASCO and EHA. This is one from ASCO presented by my own colleagues here at MD Anderson, led by Dr. Julie Braish and Dr. Lucia Masarova. And what they showed at ASCO was the impact of the JAK2 allele burden on the outcome of myelofibrosis in the era of ruxolitinib. And interestingly, the take-home points were these: that one, that if a patient has the combination of cytopenias and leukocytosis and JAK2 V617F allele burden, whether it's below or greater than 50%, these differ in terms of the myeloproliferative and myelodepletive myelofibrosis categories with distinctive outcomes in the era of JAK inhibitors, and I'll show you that in a moment. This analysis confirmed the presence or, of course, the absence of cytopenia, leukocytosis, but not really the JAK2 allele burden per se as the determiner of outcome in MF. And they found that all patients exposed to the JAK inhibitor ruxolitinib, irrespective of their cytopenias or leukocytosis, had improved overall survival, which is one of the main goals now of our modern day therapy approaches. So what they showed is that historically we have this myeloproliferative and myelodepletive myelofibrosis. In the myelodepletive, usually associated more with primary MF, a lower median JAK2 allele burden, maybe more anemia, thrombocytopenia, less leukocytosis, more high-risk molecular mutations. Response historically seems to have been limited to ruxolitinib with an inferior overall survival. In contrast, the myeloproliferative phenotype, usually associated more with secondary, so that's post-PV, post-ETMF, a higher median JAK2 allele frequency, and all the factors as you see here. So the aim and method of this sort of inquiry was to investigate the impact of this JAK2 allele burden using 50% less or greater as the cutoff on the overall outcome of patients with MF with respect to these myelodepletive or myeloproliferative phenotypes for all these MF subtypes. We looked in our database of over 600 patients with JAK2 positive myelofibrosis in retrospective fashion. And you can kind of see the groups here, basically based on the category of cytopenia and leukocytosis. So proliferative, cytopenic, both, neither. Overall, among these 600 patients, the median age was 66 years, and over half of the patients, 65%, were male. You can see them broken down here by categories based on allele burden less than 50% and greater than 50% here. Overall, the group found that post-PV or post-ETMF is actually associated with higher JAK2 allele burdens across the various subgroups. In addition, the investigators found that there was a similar survival with the JAK2 V617F allele burden and MF subtype, and that's less than 50 or greater than 50 primary or secondary MF. Dr. Braish and colleagues also found that the myelodepletive and myeloproliferative phenotypes tailor the MF outcome. And you can see the curves here clearly separating based on no cytopenia plus or minus leukocytosis, cytopenia without leukocytosis, and cytopenia with leukocytosis. Interestingly, the overall survival is found to be improved with the use of the JAK inhibitor ruxolitinib in all cohorts. And here you can see these different categories, and that's regardless of JAK2 allele burden. So in summary, from this large one-center retrospective database study, the authors concluded that the JAK2 allele burden, whether it's greater than or equal to 50% alone, does not solely predict overall survival in myelofibrosis, and that JAK2 allele burden greater than 50% without cytopenia is associated with superior OS in post-PV, post-ET-MF only. They further concluded that myelodepletive and myeloproliferative phenotypes tailor survival in MF, and that patients exposed to the JAK inhibitor ruxolitinib have improved overall survival, and that's regardless of their myelodepletive or myeloproliferative phenotypes. And so I think that's a nice abstract to review in the single agent JAK inhibitor paradigm. Now we move to the combinations at the EHA meeting, 3 that I've selected for our review. The first one is that of navitoclax with ruxolitinib. Actually, I presented myself on behalf of my colleagues, and this was a phase 3 global randomized study, untreated MF, known as the Transform-1 study. And by way of background, preclinical studies and also our own early stage phase 1/2 clinical studies showed the clinical benefit of the navitoclax, an oral BCL-XL, BCL2 compound, either as monotherapy or as combination suboptimal add-on to the ruxolitinib and a small cohort of patients frontline. So based on those encouraging data, we set out for this phase 3 Transform-1 study, and this is actually the long-term follow-up from the ASH presentation, adding several more months of follow-up. So the Transform-1 study schema is shown here. Interesting study in that the majority of these patients are intermediate risk to high risk, but intermediate 2 to high risk is the vast majority of the patients. This is defined as by the DIPS plus score. 252 patients overall enrolled. 1-to-1 randomization with the stratification shown here based on intermediate 2 and high risk and platelet count. The investigational arm shown here at the top is ruxolitinib twice daily based on package insert, and navitoclax once daily, also based on platelet count. The control arm is ruxolitinib twice daily plus placebo. Key study endpoints are shown here. The sole primary endpoint is SVR35 at week 24, central imaging confirmation required. Key secondary endpoints included SVR35 at any time during the study. Exploratory endpoints were very nicely built from the start and included looking at markers of PFS, VAF modulations, and high molecular risk mutation modulations. Demographics are shown here for the 252 patients with a median follow-up now of 20.3 months with an upwards range up to 35.3 months. As you can see here, this is a high risk group of patients. 80% or more of the patients were intermediate 2 risk. Approximately half the patients had high molecular risk mutations, median age of 69 to 70 across the 2 groups. And you can see the distribution of the mutations, which among patients who had an HMR, 1/3 of them were ASXL1 mutated. The key sole endpoint was SVR35 at week 24, highly statistically significant. The combination navitoclax arm had 63.2% of patients achieving SVR35 at week 24 versus only 31.5% in the control arm. While the statistical significance was not met for the TSS MPN symptom burden reduction, you can clearly see both arms having reduction numerically, 11.1 points and 9.7 points, respectively here. Now, looking at durability and any time of this SVR35, remarkably, when you go beyond the week 24, 76.8% of NAV combination patients achieved SVR35 at any time versus only 43.3% in the control arm. Now, when you look before and after the week 24 endpoint to see how early and how late these responses are, quite remarkable results. On the left, you'll see as early as week 12, the NAV-RUX arm showing a 62.4% SVR35 rate, and all the way out to week 48, 53.6% here. Again, showing not only the durability, but also the early onset and then durability of many of these patients. We wanted to look more at the high molecular risk patients, and patients with HMR had durable responses. On the left, you'll see duration of SVR35 by HMR status, and on the right, PFS. Overall, the median duration of SVR35 was not estimable in both arms, and the median PFS was 25.2 months in patients who received the navitoclax combination and 22.9 months in patients who received the control. Now here I'm showing you VAF reduction. On the left, you'll see greater than or 20% reduction in VAF, favoring numerically the navitoclax ruxolitinib arm, 56.8 versus 42.2%. On the right is an interesting graphic, which is change in specific VAF based on driver mutation, JAK2 in blue, CALR in red, MIPL in green. And again, you can see in the combination arm, regardless of mutation, driver mutation expression, you have VAF reduction. We next looked at PFS, progression-free survival, which is a key emerging endpoint in the myelofibrosis field. And we found that PFS in all patients that achieved greater than 20% VAF reduction versus those who did not are seen here having numerical benefit with the NAV-RUX arm. The PFS was longer in patients who achieved greater than 20% VAF reduction at any time, independent of treatment arm. And the overall survival here at this median follow-up of 20.3 months has not yet differed between the 2 arms. Anemia responses were also measured, numerically favoring the NAV combination arm, 34.4% versus 27.6%. In this longer follow-up, happy to report there were no new or unexpected safety signals, as expected and as we've shown before. The most common hematologic AEs included thrombocytopenia, vast majority of patients, anemia, and neutropenia. The most common non-heme tox was GI, which was diarrhea. Interestingly, there were no major differences between the SAEs in the two groups, actually less in the navitoclax arm. Deaths were equally distributed, as were transformations to AML. Again, as I mentioned, no new safety signals through 48 weeks. The most common SAEs were infections. This trial was done largely during the time of the COVID-19 pandemic. And although dose reductions and interruptions were mostly due to thrombocytopenia and expected BCL-XL targeted toxicity, none were due to clinical bleeding. Now, since thrombocytopenia is such an issue with navitoclax, we wanted to look at it further. So on the left is onset of thrombocytopenia by starting dose partner of the navitoclax or Rux placebo. As expected, thrombocytopenia occurred early. We were monitoring for that. But then on the right, you'll see platelet values over time in a safety analysis set. Although thrombocytopenia occurred early in the vast majority of patients, really tends to resolve over time and is easily managed with the parameters given on the clinical trial. And so in conclusion, in a stunning phase 3 trial, really remarkable to see a doubling, a twofold improvement in SVR35 week 24 in the navitoclax ruxolitinib combination, untreated frontline myelofibrosis patients versus the ruxolitinib plus placebo arm. That's despite greater than 80% of patients being intermediate 2 risk and almost half having one or more high molecular risk mutations. Now, in those patients with HMR mutations, patients who receive the navitoclax combination had numerically longer PFS and duration of response as compared to patients in the control arm. Now, while the secondary endpoint of MPN symptom burden was not found to be statistically significant between the two arms, for disease marker modifications, we did see that if patient had greater than or equal to 20% VAF reduction, this was higher in the NAV-RUX arm. And then any patients who had that VAF reduction, 20% or more, were associated with an improved PFS. In this longer follow-up, 20.3 months, there were no new safety signals or new unexpected complications. And so this shows the continued safety, durability, and feasibility of the navitoclax ruxolitinib combination arm. The second important presentation for combinations in the MPN session at EHA was presented by my colleague, Dr. Rajit Rumpel. And this focused on the safety and efficacy of the BET inhibitor pelabresib in combination with ruxolitinib, also in treatment-naive patients with myelofibrosis, also in a phase 3 study known as the MANIFEST-2 study. The schema for the MANIFEST-2 global international randomized double-blind study is shown here. Again, JAK inhibitor-naive patients, a larger study at 430 patients. DIPS intermediate 1 or higher was allowed on this study, and there was a 1-to-1 randomization based on DIPS score, platelet, and spleen volume. The treatment arm, as shown here, is the novel agent pelabresib, the bromodomain BET inhibitor, 125 milligrams POQ day, days 1 through 14, with ruxolitinib per label, 5 milligrams POBID as a lower starting dose for the first cycle, with protocol parameters to increase as per package insert. Placebo control arm was ruxolitinib plus placebo. The primary endpoint of the study was clearly met, which was SVR35 at week 24, highly statistically significant, 65.9% in the pelabresib combination arm versus only 35.2% in the placebo-controlled arm. However, unfortunately, the absolute change in TSS MPN symptom burden at week 24 also did not achieve statistical significance, with numerical reductions certainly in both arms, including in the pelabresib ruxolitinib arm, but p-value of 0.0545. A novel way of looking at this data set was presented by the investigators, which was a dual SVR35 TSS50 responder cohort at week 24. And as you can see here, there was a twofold increase in patients who had both SVR35 and TSS50 responses with pelabresib Rux versus the control arm. And again, you can see among the 214 patients treated with pelabresib Rux, 40.2% met this dual endpoint, SVR35 TSS50, 86 patients, versus only 40 patients, 18.5% in the control arm. In this novel combination, the investigators nicely showed safety Overall, a well-tolerated combination approach, as you can see here, most notably for non-hematologic toxicity, as mentioned by the investigators, with dysgeusia in 18.4% of patients. Transformation to accelerated blast phase progression is shown here at the bottom of the slide. So overall, the investigators concluded that the pelabresib-ruxolitinib combination, as compared with placebo and ruxolitinib, doubled the primary endpoint in terms of SVR35 response, which was highly statistically significant. That although there was not absolute statistical difference, there was a trend towards improvement with the pelabresib-ruxolitinib combination in terms of the absolute change of TSS from baseline, and that there were higher rates of deeper hemoglobin responses, fewer patients with transfusion requirement with the pelabresib combination as compared to the control. Overall, this combination appeared to significantly reduce splenomegaly, had a trend towards symptom score improvement, improvements in multiple areas of disease modification, including anemia, bone marrow microenvironment in this field of myelofibrosis. The third combination was shown by our colleagues, Dr. Sri Tantavati out of Utah, which is Selinexor, the XPO1 inhibitor plus ruxolitinib, and its impact on symptom burden with patients with myelofibrosis and potential for disease modification at the level of inhibition of NF-kappa B and activation of p53 pathways. This novel agent showed that there was selinexor-induced cell cycle arrest and apoptosis in MPN cells, and it was sustained with the combination with ruxolitinib. And the authors nicely hypothesized that the p53-mediated cell cycle regulation leading to apoptosis may actually explain the reduction in VAF seen in the Century phase 1 study. Furthermore, the investigators showed that selinexor-induced nuclear sequestration of p53 and other markers of activity of NF-kappa B are shown here. Reductions in plasma cytokine levels seen in the Century phase 1 may actually be attributed to the inhibition of NF-kappa B-driven pro-inflammatory cytokine production. Now, on this slide, we demonstrate potent suppression of pro-inflammatory cytokines, including IL-6, by selinexor-ruxolitinib combination. IL-6 cytokine levels at 72 hours shown on the left, and MCP-1 cytokine levels on the right. The selinexor agent, through the Export MF-034 study, has been investigated in a phase 1A dose escalation and phase 1B dose expansion study, in which the selinexor is given orally PO/Q weekly or 60 PO/Q weekly in patients with ruxolitinib. Primary endpoints are the same as our traditional endpoints, which includes MTD and, of course, SVR35 and TSS50. Now, as of February 1st, 2024, a total of 14 JAK-naive MF patients have been treated, receiving at least one dose of selinexor 60 milligrams plus ruxolitinib in this Century phase 1 study. The mean treatment duration is 55.6 weeks, and the most common AEs, as expected from the selinexor agent, was nausea in the vast majority of patients, followed by anemia, thrombocytopenia, fatigue, and constipation. Nausea was often transient in nature. Out of these 14 patients, 11 had a response, so that's 79% of patients achieving SVR35, and 58% of patients, 7 out of 12, achieving a TSS50 at week 24. So overall, in this smaller selected phase 1 group of patients, both spleen and symptom benefit were seen in this XPO inhibitor protocol. The selinexor continues in now a randomized phase 3 combination trial, selinexor plus ruxolitinib, in over 300 patients to further investigate this agent. And we eagerly await those results from the phase 3 trial in upcoming congresses. Finally, this concept of selinexor's mechanism of actions and disease marker modifications are already built into the study as shown in the phase 1, and we eagerly await those in the phase 3 as this data set matures. And so overall, my thoughts and impressions from after the summer meetings in the MPN field is that we've entered into a new golden era, a very exciting era for our patients, for our research, and for our clinical investigations. I think basically what we can focus on is what I showed you here in this updates, which is JAK inhibitor combinations several of which are now in the phase 3 randomized international trial setting. Number two is I asked the question if we can now start to aim beyond spleen and symptoms to further and newer areas of disease modification in patients with myelofibrosis, particularly these higher risk patients, in which can we measure overall survival, progression-free survival, and friend-free survival, reduction in blast, bridge to stem cell transplant, or other markers. I think it's a very exciting era to look at immune-directed and mutational specific directed therapies as we are beginning to see vaccinations, the optimization of stem cell transplant, with stem cell transplant remaining the only curative therapy in myelofibrosis, and other ingenious clinical trials modulating the immune system. The era of mutant-specific, mutant-selective targeting has now begun in myelofibrosis against the two driver mutations of JAK2 and CALR. Very exciting for JAK2. The first of these mutant-specific and selective inhibitors are now going to be in the clinic in 2024 in phase 1 testing, both type 2 JAK inhibitor as well as mutant-selective JAK inhibitor. And then for CALR, very exciting developments, as has been hypothesized with its neoepitope presentation. Could there be an immune modulatory targeting of CALR? And now we're seeing the first two, a bispecific mutant CALR by CD3 agent already now in the clinic, a monoclonal antibody directed against CALR starting in the clinic. And then we saw preclinical data at the EHA meeting for the underpinnings of a CAR T against CALR. So very exciting. We need to keep our eye on that field. And then finally, the search for new novel targets, borrowing novel targets from AML and other advanced disease states. The imetelstat agent just approved in one form of MDS. So how do we target those subsets of our higher risk patients with MF, particularly accelerated blast phase, IDH1, IDH2, for example, which has inhibitors in the AML space? We need to continue to look for the hepcidin ACVR1 pathway, so either anemia or polycythemia, depending on the disease state. And then what about novel combinations, BCL-XL and BET, for example, just to name a few. So I think overall, the main takeaway from 2024, midway through the year, from ASCO, EHA, is that we have several active novel combinations with the pelabresib and the navitoclax, both showing in very large double-blind randomized international placebo-controlled studies that the novel combinations, whether they're pelabresib, ruxolitinib, or navitoclax, ruxolitinib, actually doubled 60+% versus 30+%, SVR35 at week 24, highly statistically significant, and yet calling into question due to the MPN symptom burden not reaching statistical significance in all comers in some of these trials. And so the question that remains for us as we move forward is, are there other markers of disease modification that may be able to add or capture to the combination era as compared to the ruxolitinib and JAK inhibitor monotherapy era? And I've listed some of those here. If we can consider as a field overall survival, progression-free survival, event-free survival. Furthermore, can we start to consider transformation events to AML, number of patients bridged to transplant, blast percent reduction, and anemia improvement, transfusion burden reduction over time as key endpoints? What about at the biochemical molecular level? Can we consider adding prospectively following the VAF for all of the three mutations, JAK2, MPL, CALR, even maybe for the non-driver mutations, bone marrow fibrosis reduction, cytokine modulation, and then again, watching out for these high molecular risk mutations such as ASXL1, TP53 over time? And then can we actually directly correlate markers of biochemical molecular disease modification to the relevant clinical factors? Again, at the end of the day, improving the lives, the quality of life, the duration of life for our patients. And with that, I'd like to thank you for your time and attention. Follow me and our program on Twitter for the discussion, hashtag MPNSM, or me at Dr. Pem. Please email me or call me if you have any questions. Thank you so much for your time.